I'm Lisa Juckett, an investigator for Learn's Didactic Core, and I'm pleased to introduce today's presentation for year 3 of our series, Using Health Systems Research to Revolutionize Rehabilitation Care. Please note that if you would like to enable closed captions for this webinar, there are 2 options in the Zoom navigation bar. You can either select Show Captions if it is visible, or if it's not visible, you can select More to access the closed caption feature, and then select Captions. You can then choose your preferred language. Today's grand rounds follows the webinar 6 Mindsets to Promote Health Equity Through Implementation Practice and Science, presented just last week by Dr. Eva Woodward. You can view this and our other archived presentations using the link in the chat. Our speaker today is Dr. Allison M. Gustavson, a physical therapist and health services researcher with interests and expertise in implementation science and learning health systems. She's a core investigator at the Center for Care Delivery and Outcomes Research in the Minneapolis VA healthcare system and assistant professor of medicine at the University of Minnesota. Dr. Gustavson's vision is to empower positive changes in individuals' social, environmental, and healthcare quality of life through the implementation of interventions, practices, and policies that promote autonomy, independence, and fulfillment as people age, or age in place. Dr. Gustavson's talk will be followed by a Q&A session. We ask that you please enter your questions in the Q&A feature of Zoom so that we can address them once the talk concludes. After the presentation, we will provide a link to an evaluation survey and we'll conduct a brief poll just to learn a little bit more about who is in the audience today. And finally, we will wrap up our time together by sharing some upcoming Learn events as well as Learn funding opportunities. And with that, I'll invite Dr. Gustavson to turn on her camera and unmute herself as I'm pleased to introduce her presentation, Equitable Implementation of Innovations to Promote Successful Aging in Place. Take it away.
All right, thanks, Lisa. All right, thank you, everyone. Thank you, Learn, Lisa, for that introduction. Again, I'm Allison. I'm at the Minneapolis VA. I'm a physical therapist and clinical background. And yeah, I'm going to talk about equitable implementation of innovations to promote successful aging in place today. Let's see. Okay, just trying to find. There we go. All right. So in terms of disclosures, okay. My time is supported or was supported by an AHRQ K-12 grant, as well as some VA institutional fundings. The views expressed in this presentation are my own and do not reflect the position or policy of the U.S. government or any of my funders, and then I have no other relationships to disclose. I also want to start this presentation sharing my positionality or my identities that influence and shape my perspectives of the world. And then ultimately this presentation, really considering the fact that today is a perspective and not the perspective. So I'm a cisgender female. I'm white of Eastern European origins. I'm a mother of 3. I do not live with a disability. I was born and raised in Minnesota in a military family, and I work for the federal government as both a physical therapist and implementation scientist. I also want to start out this presentation by talking about the great authorship team that came together to formulate this manuscript. And it really is a very diverse team in terms of perspectives and backgrounds that really elevated this paper and helped me grow substantially as a researcher. So I want to thank all of them first and foremost, and then highlight who they are and how you can contact them if you're interested. So we have Dr. Jessica Lee, who's at the University of Texas in Houston. She's a geriatrician. Dr. Jason Falvey at the University of Maryland, a physical therapist researcher, and then also Dr. Matthew Miller, who's a physical therapist and researcher at the University of California, San Francisco. Dr. Shekinah Fasha Walters, who is here at the University of Minnesota. You all know Dr. Lisa Juckett, who's at The Ohio State, and then Dr. Jennifer Vincenzo at the University of Arkansas Medical Center. All right, so just a few objectives to help us frame and ground where we're going today. So the first is really to define the concept of equitable implementation. And then second is to present a customizable implementation research logic model that can guide the equitable implementation and scaling of innovations. So the premise of this presentation is based on a paper, again, I co-wrote with my wonderful authorship team, titled Equitable Implementation of Innovations to Promote Successful Aging in Place. And this really came about because I wanted to accomplish three things. The first was to reflect on how I was, or more importantly, was not integrating an equity lens into my implementation and learning health systems work. Two was to really stretch my learning on equity by gathering kind of this diverse rehabilitation and aging research group to learn from their experiences and knowledge. And then three was really to distill, again, with my co-authors, what we learned to have an actionable step for infusing equity into work going forward. So I'm committed to this journey as I continue to learn and grow and see equity as this opportunity for vulnerability and also growth. In thinking along the lines of vulnerability and growth, I was inspired by Dr. Anna Bauman's plenary on equity during the most recent Academy Health Dissemination and Implementation Conference. So that happens in December. And she made a statement that small steps are okay. And we can collectively take steps, each and every one of us, to make a larger leap in equity across healthcare and other sectors. So this concept resonated with me in my journey. So I wanted to share it with you all as we delve into this presentation. As Dr. Juggett mentioned before, Dr. Woodward spoke about in her Learn presentation last Friday, January 26th, that equity and implementation are complex, and they're really going to require a career and lifelong commitment. All right. So I always like to start out with kind of a key takeaway, because there's a lot of information, there's a lot of stuff that we don't know that we're learning and that we're getting from these presentations. So my key takeaway is really, if you don't remember anything, is that evidence-based interventions developed with equity in mind may not translate to equitable implementation. Equitable implementation is a different process that must account for different contextual barriers experienced by diverse populations of people in whatever setting or content area you conduct research in. And this is really thinking about particular attention to marginalized population, whether that be because of their race, ethnicity, gender, sexual orientation, even rurality. So just thinking about those particular groups. All right, so getting to the first objective is describing equitable implementation. So this is, again, for this paper, we conceptualize this as provisions of innovations in a manner that is fair and just and leads to improved outcomes for all impacted. And that all impacted really encompasses those who receive the innovations, deliver them, or are impacted by their delivery or receipt by the way of their presence in a community or system. All right, so this, to back up a little bit, this manuscript was originally crafted with older adults and supporting aging in place in mind. So I'm going to talk about that context a little bit and then transition into how our thinking about equitable implementation really transcends that. But older adults require frequent and complex transitions of care across the health continuum, and we know this. Yet inequities exist in access to innovations, which suggests unmet needs and inadequate leveraging of strengths and preferences for marginalized populations. So patients and families struggle with navigating decisions regarding where and how they receive care when changes in function and health occur. And this occurs despite the availability of evidence-based interventions designed to help them during that period. Okay, so again, we used aging in place innovations in this applied example to shape how we conceptualize equitable implementation. But this is But equitable implementation and the logic model really transcends the specific application to aging and researches. So this is not a unique problem to aging research is my main message there. All right, so we are now moving into the second objective, which was to present a customizable implementation research logic model that can guide the equitable implementation. So the implementation logic model was developed by Smith and colleagues to provide this structured approach to conceptualizing and designing implementation studies. So it was initially designed to map, if we kind of look at the far left, the determinants of implementation, like what can drive or hinder that implementation, what strategies can be used to overcome some of those barriers or leverage some of those facilitators. How are those strategies working to impact multi-level outcomes? And these can be at patient, system, service, and implementation level. So that was kind of roughly like what we used as a foundation. And then we were trying to think about how do we conceptualize infusing equity within that implementation logic model. And we turned to the health equity implementation framework. And this was developed by Dr. Eva Woodward and colleagues. So again, another plug up to listen to the archive presentation from Dr. Woodward, January 26th, and it was 6 mindsets to promote health equity through implementation, practice, and science. She is a leader in this area and has a lot of knowledge to share. So I really enjoyed her presentation. And if you guys want more detail, I have the references and also recommend that. But if we look at this particular model, what we took from this was these factors of implementation, which in the model can lead to successful implementation and equity when combined with facilitation, which is an implementation strategy. So over here on the left, we've kind of blown out these factors of implementation and that you can see in the model. And I want to note that there's a lot of different components and they're happening at multiple levels. There's interconnectedness, there's interdependence, because this is a complex setting in which healthcare and the delivery of healthcare resides. So to just walk through them, at first we have, and which was at the center of this model, is this clinical encounter. And this, again, for our conceptualization, we defined as the interaction between patients and clinicians that influence discussion of shared and patient-centered goals. And then the next factor was the innovation. So this is the practice, intervention, program, or policy being implemented and adopted. Next, we have the recipients. Again, these are the individuals who influence the implementation or are impacted by the implementation outcomes. So it can be the people who receive it, who deliver it, or again, are in that community or system and are impacted by that delivery and receipt. Next, we have context, and this is multi-level factors such as resources, culture, local organizational or system structures. And then, as you can see in the figure, kind of encircling all of this is social influence. And these are forces outside of the healthcare system that include economies, physical structures, and socio-political forces that are really shaping all aspects of care all the way down to that clinical encounter when we're considering, again, this equity lens. All right, so we took those implementation factors outlined in the health equity implementation model or framework, and then mapped them onto the implementation logic model to create the equitable implementation logic model. And this was really designed to provide, again, structure and actionable steps to promote equitable implementation and give researchers a tool to have some of that structure, to have that reflexivity when you're considering and designing and even evaluating and assessing as you go through a trial. So just bringing us back to the key takeaway, remember that evidence-based interventions developed with equity in mind, whether or not that happens is another presentation, may not translate to equitable implementation, again, without some structure and intention. So I'm going to walk you through an applied example of this, and I'm going to use this hypothetical care transition program that, for the purposes of this presentation, we're going to say research has shown to effectively increase days at home following hospitalization for older adults across perhaps diverse populations. So I'm going to walk through that example, and I also want to note that there is another example in the paper if you want to see different ways or different examples of how to do this. So, okay. Okay. Oh, wait. Okay, so I also wanted, and I noted this before on the previous slide, but these determinants and the strategies, the hypothesized mechanisms and outcomes are interacting factors. There's a lot of dependence, interconnectedness, and this is not in a linear or hierarchy type of structure. All right. So again, using our hypothetical example, we have this care transition program that has a large research base. When we're thinking about determinants of equitable implementation at the clinical encounter, perhaps we're thinking about communication approaches to engaging in discussions regarding an evidence-based care transition program, whether or not it would be of interest with them, whether or not it would align with their goals. At the innovation, in terms of innovation factors, we might be looking at the acceptability of the care transition program for recently hospitalized older adults. And maybe we're particularly looking at that acceptability in different racially or ethnically marginalized populations and how that acceptability might be different. For determinants of equitable implementation at the recipient's level, we're thinking about patient beliefs about the benefit of this program to meet their needs following hospitalization. Again, we're thinking about, will that benefit vary by different populations? Can we look at that? Are we measuring that? Yep. Inner and outer context. Sorry, I thought it switched there. For the inner and outer context, perhaps we're thinking about leadership support, the practices, policies, processes, resources, reimbursement pathways that either help or hinder equitable implementation. And with this, maybe we're thinking about the consequences when we're, again, designing a study, the consequences of implementing in high versus low resource settings with different leadership support and what populations may be impacted by this choice. And then at the social context level or factor, we might be thinking about locations of facilities or systems that promote care transition program as a standard of care. So if we're looking at multiple facilities, what shapes how facilities or systems operate and do or do not deliver evidence-based care either within the facility or perhaps to different populations? Okay, so we're going to move on to the next steps of the model. And for simplicity, I'm going to use one of the determinants and kind of crosswalk the example through the logic model. However, in the final slide that will be available, I will have a complete picture. And again, I mentioned before, there is a different example available in the publication as well. So you can just see how we thought about it as we were walking and how I still think about it as I'm walking through it. So if we look again at innovation, so thinking about the acceptability of an evidence-based program, a care transition program for recently hospitalized adults, how much that might, and whether or not that differs between different populations. So maybe for an equitable implementation strategy to address this barrier, we're thinking about co-creating adaptations that maintain the effectiveness and fidelity of that evidence-based program, and then work within that socio-cultural context if there is perhaps some different or variable acceptability among populations. So we want to think about a structure and methodology for tracking and implementing these adaptations that support acceptability for different populations, and also consider evaluating unintended consequences. And then if we kind of move across to a hypothesized mechanism, so if we co-create these adaptations designed to make it acceptable to different populations while maintaining that rigor of the original study, we can perhaps look at increasing the sociocultural relevance of the care transition programs. So if we increase that sociocultural relevance, can we get it more, can it be more acceptable? Do they then benefit from it and receive these better, positive outcomes that we're looking for? So again, the logic model is again, a structure for thinking about equity and implementation. And you'll still need to, I've kind of been alluding to it, but drill down on the specifics of like how to measure the delivery and the implementation strategies as well. So I put this Proctor paper here at the bottom, and this is a really good paper for guidance on specifying those strategies, and then also perhaps like mapping out how you're going to measure these effects. But again, we're just trying to map it out and think and have intention with equity and implementation. All right. So that was those three. And then if we kind of move to that far right, we're thinking about outcomes at multiple levels and how they interact across determinants. So you notice these bidirectional arrows. I think there is some iteration in this process as you move toward through a implementation study. So outcomes can be at multiple levels. Perhaps at the individual level, you're looking at increased days at home, higher quality of life. At implementation level, you're looking at acceptability again of that care transition program, the feasibility of doing it maybe in different settings, different practices, reach, who's it reaching, who's it not reaching, why, fidelity, again, making sure that we're evaluating that effectiveness and whether or not the intervention was implemented as intended, as well as adoption across different either clinics, providers, or facilities. At the service level, we might be measuring things like efficiency, safety, patient-centeredness, timeliness, things that are important to that healthcare system in terms of metrics that they might need to be reporting on and can help with overall buy-in and sustainability. Okay, that popped up again. So this is the final, again, example. I'm not going to talk through all of it, just to kind of see how one might think about this. And again, do you need I feel like there's a lot of flexibility. Like, do you concentrate on all the factors? I don't know. This is a new area of research for us as a science of implementation. And also in aging, which is the context that I work in. But I did complete it for your just to have something, but I can see it being used like the RE-AIM framework has been used in the past, where maybe you concentrate on a couple of these factors and really work on those, or empirically study these different components to see where you need to concentrate your efforts on. So again, lots of different research questions and lots of growth here. And I want to restate the key takeaway again. So evidence-based interventions designed with equity in mind may not translate to equitable implementation, again, without some structure and intention. So we need this thoughtful reflection and structure to ensure that equitable implementation. And then one way to start conceptualizing this was through this equitable implementation logic model. And I'm sure that others in the field are working on tools to advance equity across settings and content areas. So again, this is definitely a work in progress for us all. And this is one tool that you can use, one piece of the puzzle to set the stage for an equitable implementation study. So integrated at all stages of the logic model, and the need for a deep reflection and assessment of these relational contexts is equity, or well, is co-design and engagement. So I put this resource at the bottom, but Dr. Woodward recently published on learning to practice reflexivity while engaging communities in implementation science. And this describes her team's experience practicing reflexivity, again, in the content of being new to community engagement. And we're going to think about really who is at the table, who is missing and why, and what power dynamics might be at play. Power plays a significant role in who drives implementation, how efforts are implemented, and whether that implementation is equitable. So we're really at the beginning stages, to my knowledge, of understanding how these power dynamics, this co-design and engagement, shape the equitable delivery, the equitable delivery of care. So I'm not going to go just kind of beyond the scope of this particular talk, go into details on co-design and engagement, but I do want to provide some references and examples of co-design and engagement that are happening at the intersection of equity and implementation science. So the Center for Implementation has a Cultivating Trust and Navigating Power course that you can take. It's not free, you do have to pay for it, but I've had good experience with their courses before. PowerCubeNet is a really interesting platform where you can select, there's different tools to select strategies that change power dynamics and allows researchers or any sort of entities to really establish trust and authenticity. And then the VA it's a strengthening excellence in research through veteran engagement toolkit. So it was designed for veteran engagement and research, but I think the principles and the tools that they outline are applicable to other populations as well. I also put together, again, for you guys as reference at another time, like recent articles for applied examples of co-design and engagement that I've found helpful in this learning space to look at and try to understand. Again, we're still unpacking this as a field in how to best do this and what is the science behind it. So to wrap up a little here, again, this equity implementation logic model is really a preliminary tool to guide the development of innovations and empirical studies to position for rapid and equitable implementation, and then also to guide equitable implementation of previously established innovations for this broader reach and impact. So again, evidence-based interventions developed with equity in mind may not translate to equitable implementation. Small steps are okay, as long as we are all engaging and moving towards equity in all aspects of our work, as equity is a journey. I'm also adding more resources, which was really actually helpful for me to try to compile all of these. I think there's a lot of different groups doing different things on this. So just having them in one place is really helpful. The Centers for Cancer Control has a health equity toolkit, and then a really helpful implementation science bibliography for advancing health equity. The NIH Impact Collaboratory, which does a lot with embedded pragmatic care or pragmatic trials in dementia care, has a new program on best practices for integrating health equity into those types of trials. There's also a few anti-racism and health equity resources that I have seen and have been helpful in the past. And then there's also the University of Wisconsin-Madison has some great resources as well, including one on dissemination and how that touches on health equity and how equity needs to be infused in all the way from the conceptualization of the implementation trial to its dissemination. as well as the Stanford Social Innovation Review Special Issue on Equity in Implementation Science, and the Center for Implementation's Equity Toolbox. So as you can see, I think there's really a growing number of resources. I don't know if this was exhaustive, but these are things that I've used and seen before. And this growing number really indicates momentum and gravity across fields to promote equity in all aspects of research and work. So again, I want to thank my amazing co-authorship team, Doctors Eva Woodward and Jeffrey Curran for their expert review and comments on the original manuscript, Emily Hudson for assisting with making sure these slides looked really good, Learn for inviting me, and you all for attending. And then as well as these are funding sources that I've received or my co-authors in during the course of this work. I do have the references from that I cited in the manuscript outlined here. And then, so again, I want to thank you, and I open up to the Q&A with questions and discussions, and really emphasize this as an open and safe space to share, reflect, and learn. I'm interested in hearing your perspectives and experiences with equity at the intersection of implementation science and learning health systems. So looking forward to the discussion. Thank you.